All right, everybody, we'll come back together and get started. I'll mention, so I'm going to talk a little bit now about the quality metrics. I'll talk about that self-assessment tool that Kevin was mentioning before later in the presentation. But then tomorrow or Friday, I've got the email address there. WSHA and WSMA have the contact info for all of you that registered. So I'll be following up and sending out these slides, an electronic copy of these slides, and all of those tools to each of you, so you'll have copies of all of that. So the quality incentive. This is kind of the big component of the MIPS and of MACRA. That first year, it's worth a little more than half of the total incentive. And I was mentioning that what CMS has put out there is that you can select the measures that you want to be evaluated on. You can select the 6 measures that you want. The challenge is that they've given you a list of 200 plus measures, and so some of one of the big challenges is what measures should you be picking. And so trying to set up kind of a framework for how do you go from that 200, 250 down to a smaller component. And so the MIPS is about 200, 250, but there are almost 400 measures that are being used across the country between the ACO, shared savings, PQRS, all these different programs, HEDIS measures. And so looking at all of these together and coming up with essentially your organizational or your practice dashboard. What are your quality dashboard going to include? And at a minimum, it would be the measures that you'd be using under MACRA, but it might include other measures that are going to be applicable to other programs that you're participating in, or your compensation plan, other value-based contracts. And so the way we like to think about it is looking at each of the measures across 3 different dimensions about which measures are meaningful to your physicians and to your patient population. Because there are really great quality measures that just don't make sense for your population. They're things that your provider network doesn't see, and so those don't make sense for you to be thinking about. What's important for the organization? So if you already have existing programs that are in place around, if you've got a contract with a payer in your community that already includes a bunch of quality metrics, or if you have to report a bunch of quality metrics for regulatory purposes, you can bring those up as a higher priority. And then lastly, if you can't measure it, you can't improve it. So it has to be measures that you can then report out of your EHR. Preferably, it's ones that are already built in your systems that you can already report out of EHR, other reporting tools. You can go the route of creating custom reports for all of those, but they become much more challenging to have to manage year to year as the measures always change. And so thinking about those 3 areas, the clinical side, the organizational side, the technological side, scoring measures across a bunch of different categories in order to figure out which are the ones that are going to be most important to your organization and what should you be prioritizing. One of the things we like to think about is, are those measures included in a bunch of different areas? So for example, you've got measures that are going to be in the shared savings program that are HEDIS measures, and they're included in meaningful use. Measures that are applicable across many different programs. That's kind of the corollary to measures that are widely endorsed and that can be used more readily in future contracting opportunities so that you can be proactive in responding to opportunities to add quality incentives to your contracts. Looking at your compensation plan, some organizations have already started that push to add those non-productivity incentives, some of those quality elements into how they're paying their physicians. If you're already doing that, those are great measures as a way to align how the physicians are being paid with how your organization and your practice is getting paid. The use in that current contracting, as I was saying, what are you already having to report out from either current contracts or any regulatory requirements? And then assess how are you doing today compared to those benchmarks that are published already. So we were talking earlier in the slides about lining up your performance and how do you select those measures. So you can look at how do you perform today compared to the national average and use that as kind of a gauge of, are you doing well? Are you doing poorly? And how should you calibrate how you prioritize that measure? And then noting that EHR, what's reportable. And so one of the tools that I'll be sending you guys is the measure inventory. So this is almost 400 measures that apply to MACRA, as well as a bunch of different other programs, including Choosing Wisely, the regulatory things that you have to be reporting here in Washington, and give you notations about what are these measures being used in, areas where you can start notating for your organization what's reportable, what's in your current compensation plan if you have incentives, what's your current performance compared to the benchmarks that are included there. And then for MACRA specifically, you've got a couple notations here of, is it a process versus that outcome measure, since you have to include at least one outcomes-based measure. Is it a cross-cutting measure, since you have to include one of those? And then is it considered one of those high priority measures that you can use to get bonus points? And so the benefit of what this tool can do is get together with your IT team, clinical informatics, others, to fill out this, the spreadsheet, and you're going to quickly see that measures are going to stratify into high value, medium value, lower value measures, where you can say all those low value measures, not ones we're going to worry about, and take this 400 or so measures down into a list that might be 20 or 30 that are reasonable for your organization. And then this can be the basis of engaging some of those physician leaders. If you have a director of quality, other physician leaders, in looking at those measures and say, okay, what's important for your practice, what's important for our patient community, so that you can then whittle down from that 20 or 30 into, at a minimum, the 6 that you're going to want to use under MACRA, and maybe 8 to 12 or so in total that you as an organization want to focus on. And then that can lead your quality improvement efforts going forward, where you can start diving deeper into looking at how are we doing as an organization, how's each individual physician doing compared to each other, where are there significant differences, and how can we share those best practices, do some operational improvement activities on the back end. Maybe that's improving your EHR, where people are documenting the information that needs to go in, designing those workflows for people so that the MA who's going to be taking the blood pressure knows this is where you have to document it so that it gets reported in these measures. There we go. And so as you're thinking then about, once you've got that 20 or 30 measures, some of the other things you can think about is volume. You don't want to pick measures where your volumes are going to be 10 patients. The challenge with there is, A, it's really hard to improve if you don't have huge volumes, and B, one miss out of those 10 could drop you down significantly. Another one, your current performance. There's a tricky piece. The generic concept with the picking your quality metrics is you want to pick ones where you're going to do well, where you're going to be able to perform better than the average provider across the country so that you score higher. The challenge, you might look at a bunch of measures, and there are a couple where you are doing really well. Maybe you're scoring at 95, 96, 97%. That's really great performance. The double-edged sword on that can be that, A, it's really hard to improve upon that and stay up at that level at times. B, there are going to be times where the benchmarks are right up at that same level too. So 97% looks great, but that's the 75th percentile because nationally it's 98.9. And you get into situations where missing 1 or 2, again, drops you from 90th percentile to 25th percentile. So you got to be look at areas where you see opportunity for you, your organization, and your physician group to improve performance proactively, but also not necessarily choosing the measures where you're already dominant and doing very well. The applicability piece, that's kind of fitting with this idea of measures that are across multiple domains. There might be a few measures where you're not currently using them in any contracting opportunities, or they're not in your compensation plan, but they have a high likelihood that if you were approached by a payer and they said, we want to do a quality program, quality incentive with you, and you can be leading that conversation by saying, here are a bunch of measures that we know that we're tracking now that are consistent with this goal around the quality incentives, improving the quality of healthcare. So can we start the conversation from this list of measures? And then picking quality measures is not a one-time activity. As I was saying, this can set your quality improvement process for the next year, for the next several years. It should be something that you're going to be looking at throughout the year, getting regular reporting on organization level performance, individual level performance, clinic performance, so that you can identify areas that where you can improve. And then also on an annual basis, you can revisit that list of measures and say, here's a measure that we did really well and we got our scores way up. And now next year we get to pick a new set of measures for MACRA if we wish, should we revisit that dashboard and change any of those measures. So it should be an ongoing conversation. Yes. Every year you'll have, CMS will put out a new list of the measures that are included. I think they were saying in like September, October, they'll put out a call for any public comments, but then they'll put out a list of what's included, and at this point it's essentially the PQRS program that's part of it. Yeah.
Thank you. So are you saying that it's possible to pick a measure, ride it for 2 to 3 years, show improvement, and then once you've maximized improvement, move on to a new measure?
Yeah.
I mean, that it seems like that could be a way to sort of game the system.
Yeah, so they're trying to make this as beneficial and positive for providers, and they don't want to lock you in forever on any given measure. For any one performance year, though, you are set with that measure, but they do give you the opportunities to change that in future years if you want.
When you say 8 to 10 measures, are you including the specialists, or is it primarily on the primary care?
So the MACRA measures, it's going to be applicable to every provider. The adjustments in this quality incentive, they're going to be looking at the performance for every measure or every provider. One of the things, I didn't print it out because it makes this 3 slides wide. CMS did put out information around an indicator for every measure of whether it's applicable to specific specialties, and they have about 15 or so in there. And so there are 2 elements of that indicator. One is you can get it can be a good guide as to if you've got a group of ophthalmologists, what are measures we should be thinking about for them, because not every measure obviously would apply to them. The other piece is if you are just a group of, a handful of ophthalmologists, one of the things that CMS is allowing you to do is rather than going through and picking 6 measures, there might not be 6 measures that are appropriate for that specialty. So they've said in that case, you can filter down and say, here are the 4 that you have said are appropriate for this specialty. We are reporting those, and that's all you have to report. And they'll just measure you based on that smaller set of measures.
If you're a large specialty group practice, reporting under 110 or operating and billing under 110 today, does that still make sense in the future, or should you be looking at breaking out separate TINs in order to have more appropriate quality measures?
Well, that's certainly a high-level question to be thinking about. One of the benefits of having it all reported together is that if everybody's moving in the same direction, you can get better, potentially better outcomes. You get more efficiency in the work you're doing, because there are going to be a lot of times where the performance on a measure that might be very primary care focused is going to be impacted by all your specialists. And so by keeping everybody together in a single tin, you can improve performance on that one or two measures more effectively. If you do split out to a bunch of different ID numbers so that you can do more specific reporting for this specialty versus that, one of the challenges you're going to get into is just an overload of measures that you're going to have to start looking at and reporting. So you might get, if you have 10 different specialties and they're all going to have separate tins, it's going to be potentially 60 different measures that you've got to be reporting versus just having the 6 that are for that whole entity. And so we'll hand it back over to Kevin, and he's going to give a couple examples of things that organizations we've been working with are doing to be proactive and make those changes.
Thanks, John. So what you're going to hear about now is we have 4 different case studies we want to share with you, and these will largely reflect some of the same ideas and concepts that we've been talking about since we started, only with a more, this is sort of real world, how it's been applied in for some of our clients who are thinking about these issues and how to move the ball as they transition to a value-based environment. The first one is a large medical group, and the decisions they made around their compensation plan to help align incentives internally with the strategy of the group. The second one is about a hospital that really needed a managed care strategy. They had not been very structured in terms of how they approached their payer strategy, and they asked us to come in and do an assessment and give them some guidance on how to optimize what they're already doing. The third one is about population health at kind of an operational level. Within their clinics, they didn't have the right sort of optimized operational structure to do what they wanted to do in terms of care delivery, and came up with some new plans on that. And finally, we helped a community hospital go through the process that John just described of, starting with the whole universe of quality metrics that are out there and help them winnow that down to something that was meaningful to the physicians and aligned with where the organization was going. I'm going to briefly walk through each one of these, and then we'll talk about some of the tools that might be out there for you guys to do this on your own. So this was a group that was rapidly evolving from a fee-for-service-based culture. They had traditionally been a pretty high-performing, high-productivity group to a platform that was much more focused on value delivery. So they were very focused on the cultural transformation that needed to happen, and saw the realignment of physician incentives as something that was really critical to that piece as well. Again, sending a very strong message throughout the organization that it's not business as usual, that we're going to evolve. So they had a heavily incentivized based on volume, like many of our clients. They had sort of tiered RVU payments where you got paid X dollars per RVU and X plus if you cross some certain sort of threshold. Kind of reflects the incentives of private practice is what they had historically tried to duplicate, pay physicians more and more as more and more of their overhead was covered. And so they had succeeded in getting exactly what they wanted, which was a very busy group of doctors who were focused on volume. They had this was interesting in that they had. While the primary care group was pretty cohesive, the specialty component of that group was not. They usually had individualized compensation plans. They go out and strike deals with individual doctors, and so they did not really have that cohesive culture that extended across the continuum. It was really only within primary care. And so they were looking at that too. They wanted to put together a single plan that would bring all the providers together, not just primary care, as well as something that would facilitate that cultural reinforcement about the need to align around value in the future. So we worked with them, and folks who have been through this know that the process for this and the communication with providers is just so critical. That so we worked with them to understand the perspective of the specialists and the primary care to get a sense of what they were worried about, what their goals were, what they were really trying to achieve, and work with a number of different steering committees to ultimately build consensus around a plan that looked something like this. So for primary care, they did decide to go to first of all, they introduced a piece around panel size and patient experience that was new to the organization at between 10 and 25%. They saw that ramping up over time. Quality and value incentive at sort of the 15 to 25%. And production, they reduced over time from 100% down to 75 and then ultimately to 50. So a pretty big change. It actually moved a lot of money around, and so we supported this with a transition plan too that gave physicians a chance to adjust. For specialty care, a very similar sort of evolution with actually a little bit more push to quality and value. That with the value-based strategies that they were incorporating, they saw that as being even more important for some of these high-cost specialties to really drive down utilization and cost within the hospital. So they're even more keen on that for specialties than they were for primary care. And for coverage-based specialties, which usually present some special challenges, very much like the other specialists, though. A base salary or shift-based pay, depending on the specialty. Hospitalists, I think, run shift-based at 60 or 75% of the total. Quality value still at about 25 or 30%, with a very small productivity incentive, reflecting the fact that some folks actually do work harder, even in a shift-based environment. So it was important, I think, to address each of these three constituencies a little bit differently because they did have different needs, but ultimately we got to a plan that had a lot of commonality across the group and really did serve to reinforce their culture. Sure.
Give me an example of the math of one of these. You know, I mean, how do you build it? Just to say 20% is quality, what is that?
Well, we
You know,
would set up.
In other words, if I have so many work RVUs and I want to get away from volume, how do I incorporate quality into my current way of compensating?
Sure. Great question. It begins with really defining sort of a compensation pool that's out there, based on the organization's overall level of revenue. Okay, and this is a concept that is, more often you see it in larger groups and in employed groups, less often in smaller groups where, frankly, it's much more of an eat what you kill sort of mentality, where there's, you think about collections and every physician has their own collections. But in this sort of environment, you think about a compensation pool or a compensation budget and different ways to allocate it, okay? So you might start, example with, suppose the whole, collections of the organization is $1 million, just to pick a round number. You might run at 60% overhead. You have $400,000 left for compensation. You could think about that as the compensation pool and target X% of that for quality and distribute it based on differential quality scores. And within that, you can, there are lots of ways to do it. Sometimes it's a single pool, and essentially the physicians are competing against each other within that pool for that distribution. And you can do the same sort of thing for production. Now, note that under this sort of model, there's going to be a much smaller dollar per work RVU that's associated with each incremental RVU because so much of the money is being paid through other sorts of incentives. Okay, so under the prior compensation plan that was very much productivity driven, physicians might have been making $50 per RVU. Under this sort of model, they're making $25 per RVU. And so, yeah, it's a smaller production incentive, but that reflects that you want physicians focused on things other than production. Sure.
I can share a little bit about how we do it, and what we do is we say for a specific specialty, let's take pulmonary critical care medicine, we say the median salary in this region for that specialty is $400,000. And currently we provide a 10% quality bonus. So we say that the quality bonus is worth $40,000, 10% of median. So for the high producers, it may be less than 10% of their total compensation. And for the low producers, it may be more than 10%. But most of them come in fairly close to that, that median income. And if we were to make it 20%, we would just double it. We would just say 20 times the median income for that specialty. So that's one way to do it.
Yeah, exactly. And so, and that's very typical of the health systems that we work with. They tend to think of the budget as, they start with thinking about the market. Like, what do I have to pay my physicians? And so you'd start with benchmarks and build the budget up that way. For independent physician groups, they don't have the, they don't have 200 days in cash to rely on, so they tend to think of it in terms of what funds am I going to have available to pay. So let's start with looking at the budget and annual collections, those sorts of things. Okay. Thanks, Dennis. Next case study. There's no more questions about comp. So managed care strategy. This was an organization that had they actually had a lot going on in terms of a value-based strategy, but it wasn't really a strategy. It was really more tactical. What had happened is that they had been approached through the years with different payers saying, hey, you want to try this? Do you want to try that? And so they had kind of a lot going on, but it was really fairly reactive. But through the years, they had accumulated a fairly good size, value-based enterprise, as you could call it. They had 4,500 Medicare Advantage lives and about 20,000 Medicaid managed care lives, but without really an organized plan. Okay, so you can tell by the ratio of Medicare to Medicaid here, this was a relatively large system, but in still an area that was predominantly rural, so a high Medicaid population. So the board had really pushed administration to take a look at the various programs that were out there. MACRA was just being introduced, and they're like, okay, so what does that mean? We have all this managed care and value-based stuff going on. Should we shoot for APM or not? Was sort of the question that inspired them to take a look at this. So we looked at a value-based readiness assessment for them in collaboration with hospital leadership. John's going to talk some more about what that looks like here in just a minute. We looked at, financially, how you're doing. Are you making money with these different plans that you have out there? How does it compare to, Medicare becomes kind of the benchmark. On a percentage of Medicare basis, how are you actually doing on these? What sort of care processes do you have in place? What sort of medical management? Do you have the infrastructure and are folks on the same page? So we help them design strategies around the various CMS initiatives that are out there, and there are a lot of them besides MACRA that are beyond the scope of this discussion. But there are a lot of things out there, lots of different tracks for the shared savings program now, comprehensive primary care initiatives, all those sorts of things. And so we helped them evaluate that in light of their hospital reimbursement, their physician reimbursement. They also had some rural health clinics. So a pretty complex reimbursement environment, and we essentially helped them optimize their revenue and their strategy, putting all those things together. And then we helped them pull together an implementation plan to help round out what they were doing in population health and make it more cohesive. So here's a summary of some of the things that we found. We found that although they were doing a pretty good job of managing care, there was still a lot of out-migration out of the market. It was mostly driven by employers and payers, not by patients. Patients were happy to stay in town, but because of different insurance relationships, they're often being pushed off to a nearby metropolitan area. And so our strategy to help around that was to develop a clinically integrated network with some neighborhood physicians, as well as some of the other payer strategies. We identified they had issues with patient access, especially in the rural areas, and so the initiative there was to look into telehealth, develop strategies to enable folks to access care more remotely without having physicians have to incur the drive time and other real costs like that. There are pockets of clinical optimization, but they were really more focused on specialties and a few service lines, but they really needed to have more of a concerted effort across the entire physician enterprise to do a better job around care delivery. We also observed that they had very little in the way of analytical capabilities to even do the reporting that was going to be required from MACRA. So they had a lot going on in IT, and all their analysts were really busy, like all the time. And so we just said, hey, you guys got to bite the bullet and hire a couple more folks, clinical informaticist types who can really get in there and figure out what's going on using your existing data. And then finally, their compensation plan was not all aligned with where they were going. I mean, they had almost 25,000 lives under what was close to full risk, and their compensation plan was 100% productivity. Okay, so the physicians were definitely getting mixed messages about where the organization was going, and there's a plan in place to revise the comp plan going forward. Yeah, Bob.
Just a quick question on the last point that you raised about, just bite the bullet and hire a clinical informaticist. One of the issues is certainly the availability of qualified workforce in that area. So
yes.
How do you traverse that? Go find somebody?
Go find somebody,
Okay.
yeah. Yeah, Bob, that's absolutely true. Some folks have had some luck in grooming folks internally to do that. There are sometimes folks with a clinical background who get it in terms of not only what the data means, but how to make corrections for it in different operational environments and things like that who are analytically oriented. And so we've seen some folks have that. You may have people who are just burned out on doing clinical work and want to try something different, have an analytical mindset, that sort of thing. So no easy answer, but you're right, it can be tough. Especially in this area, it's going to be tough too, rural area. Let's see. So kind of more strategically, we thought that they should take a look at a lot of those other Medicare initiatives that were out there to see about qualifying for an APM. We thought that they were definitely going to miss it in the first year because their lives just wouldn't qualify. I mean, one of the things that's kind of a mystery in MACRA is that Medicare Advantage doesn't count. And that's where a lot of folks have started because it's a good place to start. But there's no allowance for that in terms of qualifying for an APM. So they were going to look at shared savings programs. They were going to look at some other things, sort of pending the review of the profitability of what they were doing in Medicare Advantage. Including pursuing an additional Medicare capitation arrangements with a commercial payer that had just launched a new product. They were going to look at their existing fee-for-service contracts to get some additional incentives in that, because you're gonna turn the company around. Like I said before, you might as well get paid for everything you're doing to do that. So they were looking at infrastructure build. They were looking about changing clinical protocols, and there was a large part of the reimbursement for which that would actually cost them money. So they wanted to start thinking about adjusting that. And also, there were some employers in the area that when we talked to them were interested in things that were kind of outside the health plan environment and that were maybe a little more innovative. Turns out they were sending a lot of these patients out of town because they thought they could get better care for some high-cost procedures at the nearby metropolitan area. And so we were developing bundles for them between those employers and this particular client that looks like are going to be successful as well. Okay, so thinking about population health, and this was really approached from sort of an operational mindset. This was a clinic that was having problems. It's actually a hospital-employed clinic that was operationally having problems that were prohibiting from taking their care model to the next level. So we wanted to revise patient flow and scheduling processes, develop more of a patient-centered model around care, and really help them move the needle in terms of their overall culture, which was very much oriented around the providers and what the providers needed, and not really around what was going to work for the patients. So we helped develop a future state model and implementation plan to get them to revise their operations. So they started with the current state was they had a nursing pool for most of their clinics without really cohesive teams. Okay, it was sort of based on the needs of the nursing staff and the providers. Basically, they'd utilize whoever was available in terms of being scheduled for seeing patients, and was really again designed around what the providers wanted and sort of what they had already done. It was not unusual for providers to cancel clinics with very short notice, and that sort of thing. The future state that we helped define for them was much more around a team-based approach that included incorporating some mid-level providers. Included having greater definition around what MAs and RNs were expected to do within that model, and appropriate staffing levels that were standardized more across similar sorts of physicians. Ultimately, we piloted the new approach in 3 different clinics and saw definitely improvements in patient satisfaction from this new approach. But it didn't stop there. We also, some of this is sort of the basic blocking and tackling, but sometimes that's where you need to start before you can think about doing things that are more advanced. So we did standardize the guidelines and approach around chart prep, around who's responsible for rooming and patient workups, and some of those things that you just have to do. Standardized staff roles and responsibilities, moved to daily huddles so the care teams could get together and talk about what's really going on today, where might we have availability in the schedule, where can we work people in, and those sorts of things. Worked on an approach to team communication that was much more effective than what they had before. Shared inbox pools and things like that to help better redistribute the work. And the clinic also set up a leadership task force to really sort of lay the groundwork for future innovation that might happen. So again, these guys weren't quite ready to do the more advanced population health work. They were really starting from a much more basic setting. But I think once they move past this, they're going to be ready for kind of the 301 level on population health. And finally, the last one I'll walk through reflects sort of the process that John described around working with an organization who might look at this set of 200 or 300 different metrics for MACRA and just trying to decide, my gosh, how do I do this? Where do I start from? And it was really about finding that sweet spot of things that we can measure. okay, which isn't that whole universe. Things that our doctors care about, which is going to be a much smaller setting of it, and also those things that are important to the organization because ultimately there's going to be incentives tied to them. And we're all going to be in an environment where MACRA is not the only thing that we care about, right? Medicaid, state Medicaid is coming up with their own list of incentives that we hope will have some overlap with MACRA, but let's not hope too much, it may not. There are other incentives out there around HEDIS. Other health plans are pushing their own things that need to be reported. Sometimes boards get really fired up over wanting to see a couple things, and all those are important inputs to this. And the tool that we're going to share with you, it lays out all those metrics as well as the domains in which they're important. And so trying to find ones where you can tick as many boxes as possible is probably a good strategy in the environment we're in, which is we don't have enough information, we don't have enough people to collate that information. So we really hope these guys go through that process. They had, ultimately their goal was to increase the percentage of revenue from value-based contracts to nearly 60%. Okay, so they were all in. Okay, they decided we're going to be a value-based organization. Here's how we're going to do it, and they realized that they weren't where they needed to be in terms of their quality metrics, and MACRA was coming too. So it created heightened interest in getting on with this. So we looked at nearly 400 different metrics. We collected those. We categorized them based on the number of those measure domains that they could tick off, based on how much work it would take to measure it in terms of operationally, which ones are ready to go, which ones are going to take a ton of work to get there, and where we thought their current performance was, where we actually had the data to do it. And then we called together a group from their employed physician enterprise to kind of do the hard work of thinking about the pros and cons and really finding that sweet spot. Okay, and so ultimately we came up with 12 different measures, and they've been developing sort of best practice workflows around that to help make sure that they can really hit it out of the park with those 12 that they've selected. So here's what the answer sort of looked like. Again, I'm going to send this to you, and you probably can't read it anywhere from where you are. But we did think about it across their major specialties that they employed, and of course for primary care. And this is essentially the work that committee completed in terms of picking the measures that they were ultimately going to report back to CMS. Okay. Of course, your mileage may vary. Every information system is going to be a little different. Physicians are going to be fired up about some measures and not about others. But it's really it's sort of about that process again of figuring out where that sweet spot is, and it's going to be different for every organization. Okay, so this had a number of different benefits for them. One is that they were more advanced than some other folks that they were working with in sort of a mini CIN. Because they went through this process, they were really able to kind of set the agenda for that. So when those organizations came together to think about what quality metrics are we going to provide, they'd already done their homework, said, hey, here's what we think is really important and can be measured. And they're ready to go for MACRA next year. They're not going to be in one of those, the mini MACRAs. You report one or only report a quarter. They're going to be in for the whole year next year because they've done their homework and are ready to go ahead. And also, while we're a little bit before we started this, they were approached by a commercial insurer that wanted to incorporate a quality incentive into the 2017 contract. And again, because they'd done their homework, they were able to kind of put more eggs in that basket in which they'd already been investing. So they had really made an organizational commitment to these 12 metrics and said, we're going to redefine care processes, we're going to make sure we have them measured, we're going to make sure we have all our specialties aligned, and they were able to propagate that to other contracts when the payer started to approach them about entering into similar arrangements. So in this case, I think it really paid off for them that they did make the investment up front, but they were ready to go. And to John's earlier point, this is not something you're going to do once and forget about it. This organization has stood up several committees that are probably going to exist again forever, for the rest of their careers, where they're going to be doing this and tweaking those measures and probably adding a longer and longer list of those to what they do every year. Any questions or comments on that one? Okay, so let's talk about resources and support to help you guys figure out your own strategies.
All right, so lots of information, lots of things to do. One of the questions that we often get is, where do we start? We've taken all this, there's a lot to do. Where do we start? What do we focus our time and energy on? So Kevin early on had talked about a bunch of different areas within the organization that all have a role in transforming you into a value-based organization, the things that you'd need to do to succeed under MACRA, under other contracts. So what we have is a self-assessment tool that you can take, that your leadership team or various people within your organization can go through this tool and score yourself to think about how are we doing in all these different areas, and that can help you focus your attention to those few areas where you have the least infrastructure, the least development. You can start building up your capabilities there. So there are the 5 categories that Kevin was talking on, or touched on earlier, from the care delivery model, your provider network, IT, payment models. Within that, we've got 22 or so different capabilities, and then 150 questions within that, where you're going to score yourself from a 1 to 5 as how developed are you, as how is your organization developed in terms of the capabilities, and if you had a value-based contract tomorrow, would you be able to implement this now or in short order? So questions going all the way down to the level of, do you have an EHR, and how widely adopted is that amongst your provider network? And so a couple snapshots for you to give you a sense of what does it look like. So you've got in care delivery transformation, you've got within that a capability of care coordination. So how are you doing within the hospital, your physician group, access to ancillary services as well, scoring yourself 1 to 5, and then this thing will automate and score you up within each area to give you an idea of how you're doing. And so the implication here is that anywhere where you're scoring a 3 or below are areas that you need added focus. If you're scoring above that 3, you're doing fairly well, and you can touch on that later on. And then ultimately where this ends up is then giving you kind of a sense of, are you ready for these different type of value-based models, beyond just thinking about MACRA, but in conversation with other payers in the market? Do you have the capabilities where you could realistically do well under a pay for performance model, or have you developed the infrastructure so you could dive into a shared savings arrangement that has both the upside and the downside with confidence? Or do you have a few areas where, let's spend the next 6 months and develop these few capabilities, and then we feel like we could really dive into that more fully? And so when we send you these slides and all the materials, I'll send you this workbook so you can take that and score yourselves in a little instruction guide on how you do that. The other thing, can't leave here without putting a plug back for materials that WSHA has put out, that WSMA, they've put some things on the back here, but they've got lots of information on their website. They've got lots of staff that are able to support their members as well, and so you can connect with them with any questions you have specifically for any added help. And anything you both wanted to add, or I can...
Again, Bob Parno with the Medical Association. One of the things that we've got very good feedback on is on our website we do have a dedicated page for MACRA. We try to break some of this down into sort of a simple 3-step process. Certainly this group is much further ahead of the curve and more informed, but certainly bringing your whole organization along, I think, is one of the challenges. We've tried to break down this into step 1 is really understanding value-based care, second, understanding MACRA, and then also thirdly, doing a MACRA checklist, and we worked with the AMA on those materials. And we touched briefly on APMs. We also had done a program with Harold Miller on June 25th here at the Marriott on alternative payment models, and that's available as a pre-recorded event as well on our website. So, Kathy?
And then I'm the one working on the Hospital Association site on MACRA. We also have a web page. I'm fairly new, so I'm building our web page as quickly as I can. But any questions about this, you're free to reach out to me. And we're working with our patient safety and quality department on the quality metrics and trying to help you guys align your metrics across state and federal regulations. So that's where I'm at.
Oh, hi. So I'm Sharon Elorant, and this is Kathy Schoenrock. We're from Qualis Health, which is the Medicare Quality Improvement Organization for Washington and Idaho. And under that contract, we are to support all practices that have 15 or more providers in helping them prepare for and hopefully become successful at making their decisions what they're going to do with regard to MACRA or MIPS. Yeah, obviously, I believe there's around 30,000 eligible clinicians in our state, and I think we've kind of ratcheted that down. But the good thing is that we have an active partnership with both the Hospital Association and Medical Association, so that we're all trying to combine our resources to make sure we're sending people to the same places. We're not going to be doing 50 different webinars on the same topic, but really collaborating to try and get that support out. But feel free to contact us if you have worked with us already on interpreting your QRUR or any of that stuff. This is the next part of that.
And then want to make that final plug for December 14th, that webinar that's being put on by WSMA and WSHA, being hosted by Dr. Fisher, to really do a deep dive about the thought process and the rationale behind all those final rule changes and any final questions you may have. So that's it. That's a lot of information, and any questions you guys have, feel free to ask now, or you can come up and we can chat on the side here as well. Thank you.